This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our neurology podcast collection. Whether you are new to neurology in training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology, easily, one podcast at a time.
Happy New Year. It's Jeff Ratliff, Deputy Editor of the podcast, welcoming you to both 2024 as well as the January episode of Neurology Recall. In this month's episode, we are featuring interviews conducted in recent months on various topics in dementia. In the first interview, you'll hear from Roy Hamilton as he interviewed Kenneth Langa on the February 2nd, 2023 episode of the podcast about a paper on estimating the prevalence of dementia and mild cognitive impairment. Following that, you'll hear an interview that aired just a week later on February 9th, 2023. In this interview, you'll hear Jeff Burns interview Beau Ances about his paper comparing the amyloid burden in patients with Down syndrome and autosomal dominant Alzheimer's disease. In the final two interviews, you'll hear frequent podcast contributor Greg Day. In interview number 3 of the episode from the December 29, 2022 episode of the podcast, Greg spoke with Erik Musiek about lecanemab in early Alzheimer's disease. The final interview in this month's recall aired on October 12, 2023, in which Greg spoke with Vijay Ramanan about patient eligibility for anti-amyloid treatments. We hope you enjoy these episodes and will learn some pearls of wisdom to bring to your patients with dementia. Thanks for listening to the Neurology Recall on the Neurology Podcast. We'll see you next month.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology Podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Roy Hamilton. I'm a behavioral neurologist at the University of Pennsylvania and one of the associate editors for Equity, Diversity, and Inclusion for the Neurology family of journals. Today, I have the distinct pleasure of interviewing Kenneth Langa, professor in the Department of Internal Medicine and Institute for Social Research, a research scientist in the Veterans Affairs Center for Clinical Management Research, and an associate director of the Institute of Gerontology, all at the University of Michigan. Dr. Langa's research focuses on the epidemiology and costs of chronic disease in older adults, with an emphasis on Alzheimer's disease and other dementias. He's one of the co-authors of the paper titled Estimating the Prevalence of Dementia and Mild Cognitive Impairment in the U.S., the 2016 Health and Retirement Study Harmonized Cognitive Assessment Protocol Project, which appeared in the October 24th, 2022 issue of JAMA Neurology. Ken, welcome to the Neurology Podcast.
Thanks very much for having me, Roy.
In this study, you and your colleagues examined a large, nationally representative cross-sectional sample of persons who were 65 or older in order to provide updated estimates of mild cognitive impairment and dementia in the U.S. Now, prior studies have estimated the prevalence of these conditions. So why did you and your co-authors feel it was important to provide updated demographically representative estimates of these dementia and MCI diagnoses now?
Dementia is a huge and growing public health issue in the United States and around the world. With the aging of populations, there will certainly be an increase in the burden of cognitive decline and dementia in populations just because of the increased number of older adults. It's also a sort of fascinating time in trying to understand Alzheimer's disease and dementia with actually some good news over the last 20 years. It seems as though in lots of high-income countries, there's been what seems like a decline in age-specific risk, probably due to increasing levels of education, maybe better treatment of cardiovascular risk factors. On the downside, there's also been growing evidence of increasing disparities in health, both health in general and brain health in particular. So for all those reasons, we thought that it was important to do this new study based on a large representative sample in the United States.
Now, participants in this study were selected from individuals being followed in the Health and Retirement Study, or HRS. You're the associate director of the HRS. Can you describe that ongoing study and talk about its usefulness as a research tool?
The Health and Retirement Study is an ongoing panel study, started collecting data in 1992 for a representative population of adults in the United States, 51 years and older. It's been funded by the National Institute on Aging, the Social Security Administration since starting 30 years ago now. And the HRS collects lots of different kinds of data. It's not just a study of dementia and not just a study of health. Actually, we collect information on occupations and economic factors, family factors, relationships among the family and generations, and caregiving, psychological aspects of aging also. So all of that information is collected, and a large representative sample, about 20,000 people, are interviewed every 2 years. Almost 40,000 people have been in the study at some point over the last 30 years, again, since data was collected. Importantly, all of the data are made public. Everyone listening to the podcast can go to the HRS website and download the data, again, to study all these different aspects of aging.
What an amazingly rich data set to pull from. Can you tell us about how participants for this study were selected and how many eventually participated, and what did you ask them to do?
This Harmonized Cognitive Assessment Protocol, or HCAP, that the data from which were used for the study we're talking about today, represents actually the second sub-study on dementia that we've done with the Health and Retirement Study as the base or the infrastructure. The first one was called the Aging Demographics and Memory Study, or ADAMS. That was performed back in the 2000s. The HCAP aimed to collect data on a bit larger sample than ADAMS, again, particularly to be able to do some additional assessment of racial and ethnic and education differences in dementia risk. So for the HCAP, we drew a sample of about 3,500 people who were 65 and older who participated in the 2016 wave of the HRS. About 79% of the people that we invited to participate in the study did participate, so a pretty good response rate of 79%. And again, this was a random sample of people 65 and older, which provided a good number of people, again, in minority populations like African American and Hispanic individuals were included in HCAP. And in order to collect information on cognition and function, we put together this 1-hour cognitive assessment using existing cognitive screening tools or cognitive tests, things like the mini mental state, Ravens, matrices, wordless learning. All of these obviously are in the paper and additional information. But the idea was to put together about an hour's worth of testing. Again, we did all of these assessments in people's homes, didn't want to make it too burdensome. We also had about a 20-minute informant interview using, again, existing protocols, things like the Blessed Dementia Scale, Jorm's IQ code, and tests like that. So the main goal was to get good and wide-ranging cognitive information across different cognitive domains. Again, common things that are tested for dementia, things like orientation and memory and language and executive function, visuospatial skills. And then all of that information, both from the respondent, the cognitive testing, as well as the informant information, was put together, and we developed an algorithm to classify people as normal cognitive function, MCI, or dementia.
Well, it sounds like you were able to capture a broad range of cognitive abilities and come to a pretty good assessment of the cognitive abilities of the participants in the study. So let's talk about the results. Overall, how prevalent did you and your co-authors find MCI and dementia to be in this sample of individuals? And how does that compare to what had previously been shown in the literature?
Our overall results that were about 1 in 10 adults in the United States, about 10% of the 65 plus population had dementia, and about 22% had mild cognitive impairment. And those main prevalence estimates are relatively similar to other studies. A study that's often cited is the Chicago Health and Aging Project, which was done in the 1990s, led by Dennis Evans. And that study has found a bit higher prevalence than we found here or than was found in ADAMS, probably because of some differences in criteria and who's in the MCI and dementia groups. Their estimate was a bit higher, about 11% from a publication, I think, within the last year or two. Other studies like the Global Burden of Disease study have used other methods and modeling to look at recent overall estimate of dementia in the United States. They found a slightly lower prevalence than we did in this HCAP study. But again, I would say that the estimates are within a similar range, sort of between 9 and 11% or so in the United States. Similarly, the MCI estimate of 22% is, in the neighborhood of what other studies that weren't using national samples were using more geographically restricted samples.
So it seems like overall, the findings were fairly comparable, at least with respect to prevalence, although for the reasons that we discussed, you captured data in a broad, representative, very robust sample. Now, the nature of your data collection, the cross-sectional nature of your study, allowed you to assess patients across a range of ages. And also, because your study focused on sampling participants who reflect the demographic composition of the U.S., we were also able to look at factors like race, education, and sex. Can you discuss what demographic characteristics your team found increased the risk of dementia and mild cognitive impairment?
The main risk factor for dementia, increasing age, was found, as expected, to be older adults at higher risk, range from about 3% of those who were in the 65 to 70 range up to over 30% for those 90 plus. Like many prior studies, also found that higher levels of education was protective against dementia and MCI. And then in terms of the key issues of racial and ethnic disparities, we did find, again, as many other studies in the United States have found, a significantly higher risk for African Americans, odds of about 1.8 higher odds of dementia among those who are African American. Hispanic individuals actually had a similar rate of dementia compared to whites in our study, but had a significantly higher rate of MCI. So higher risk of dementia among African Americans, higher risk of MCI among Hispanics. Also, for individuals who we had to group as sort of other race because of small sample size, folks who are in Native Americans, Alaskan Natives, Asian individuals also had higher risk of dementia overall.
Ken, I'd like to focus for a moment on your findings with respect to race and ethnicity, because I appreciated how you and your co-authors framed these categories in the paper. In the absence of some additional context, I think some listeners might hear your results and come away with the impression that persons who are Black or Hispanic are somehow intrinsically prone to develop cognitive impairment. So when you're characterizing the influence of race and ethnicity on dementia and MCI in this study, what did you and your co-authors understand that you were assessing?
The categorization of race in our study, both in the HRS and the HCAP specifically, was a self-report. We asked people to tell us what race and ethnicity they viewed themselves, sort of using the categories that are used in the census. So we would sort of conceptualize these categories as, social constructions, nothing sort of biologically based. And I think, and obviously the key questions are, why is it that African Americans, those who self-report as African American, seem to have a significantly higher risk of dementia? And almost certainly, much of the increased risk is related to life course social factors, things like access to fewer opportunities for quality education, occupations, living in neighborhoods that are likely more stressful. Also, probably lots of interesting work now being done on environmental exposures throughout life, both sort of toxic exposures, things like lead, as well as pollution and all of those environmental factors that in African Americans, those likely have greater exposure to through the life course. And then issues of discrimination and the stresses that go along with that. These are obviously extremely complex, but very important causal pathways to sort out. And again, we think that that's one of the important reasons for collecting these kind of data in a large representative sample.
Thanks, Ken. All of those points are so important with respect to how disparities arise and how they affect neurologic health. So thank you. I want to take a moment to take a big picture view of this work. Can you talk more broadly about the value of tracking dementia and MCI in large demographically representative samples like the HRS?
We think a large population-based and representative sample like the HRS is important generally, but also particularly around trying to understand brain health and cognitive decline. those of your listeners familiar with the recent controversies around clinical trials and the representativeness of clinical trials, for instance, for anti-amyloid medications like aducanumab, that lots of debate and controversy recently that many of these clinical trials have not included many African American or Hispanic participants. So the questions still remain, are the results of these trials generalizable to minority populations? Again, I think both in treatment trials, but also in some of the volunteer trials or any study based on a volunteer sample or clinical samples where there isn't significant representation of minority populations, there remains the question, are the findings in that study generalizable?
Every study, of course, has limitations. So can you talk a little bit about some of the potential limitations of your study?
We are making these kinds of classifications or diagnostic classifications using much more limited information than would be typical in a full clinical exam. The really, the balance that we're always trying to address in a large population-based study is that kind of in-depth clinical assessment and imaging and things like that is just, not feasible in a 20,000 person sample that's nationally distributed. So our holy grail, so to speak, is to try to get enough data and enough information where we make these classifications in a valid way and that, line up with what we hope would happen in a full clinical exam. A direct ramification of that is that we didn't feel comfortable making assessments of subtype of dementia, for instance, so Alzheimer's disease versus vascular dementia versus FTD or things like that. So that's certainly one limitation. I would say another limitation which will be addressed going forward is that this is, as you mentioned, a cross-sectional study. So we were doing these classifications in one point in time. We are now collecting the second wave of the HCAP data this year. We were actually scheduled to do it in 2020, but obviously had to delay that because of the pandemic. But we will have longitudinal data to follow up, hopefully even improve these classifications, understand things about incidence, not just about prevalence. And we think that will provide additional information and power for the study. And then I guess finally, even though a main goal of our work and methods was to increase the number of individuals from minority populations, African American and Hispanic, there's still some of those other important groups, folks like Native Americans and Alaskan Natives, still don't have enough of those individuals to really have power to look at potential differences in prevalence and risk across those groups. We're still thinking about it and talking with NIA, our funders, because trying to get to groups where there is smaller and smaller numbers and representation obviously costs increasing amounts of money, but it is something that's an important priority at NIA, and we're hoping to expand representation of some of these other groups going forward.
Well, it sounds like there is still room for plenty of further exploration. But despite any limitations that you just recounted, I have to say that this is an outstanding investigation that updates and solidifies our understanding of the prevalence of dementia and mild cognitive impairment in the United States. It underscores the important disparities experienced by Black and Hispanic persons and persons with lower educational attainment. And it reminds us of the need for diverse representative samples in research studies on aging and cognition. Ken, do you have any final thoughts for our listeners?
Please go to the Health and Retirement Study website. If you Google HRS or aging, you'll get there at the University of Michigan. Take a look at all the data that we have. We didn't get to talk about some of the genetic information, biological blood biomarkers. We also link to administrative records like the Medicare records. So really rich data source, again, all publicly available. So I would encourage your listeners to go there, take a look at all of the data. One of the aspects of the HCAP study is that it was developed with the specific goal of allowing international comparison studies. So there are now about 40 countries around the world that are doing aging surveys, aging population studies patterned on the HRS, about 15 of them now doing a similar HCAP data collection. So for those interested in international comparisons of aging and dementia risk, all of those data will be available there too. Also invite listeners to, there's a place to get in touch with us at the HRS. We're always interested to hear about what we could do better and the kinds of data that people and researchers are looking for to do better work. So would invite everyone to get in touch and let us know how we can do things even better going forward.
Well, great. Ken, thank you and your team for an excellent article, and thank you for today's interview.
Great. Thanks very much, Roy.
Hi, I'm Jeff Burns from the University of Kansas Alzheimer's Disease Research Center, and I'm speaking today with Beau Ances from Washington University in St. Louis about his paper recently published in Lancet Neurology titled Comparison of Amyloid Burden in Individuals with Down Syndrome versus Autosomal Dominant Alzheimer's Disease, a cross-sectional study. Welcome, Beau.
Thanks, Jeff. It's a pleasure to be talking to you today.
Great. Yeah. So in your paper, you present an interesting analysis of data collected from a large Down syndrome cohort from the National ABCDS network and from a cohort of individuals with autosomal dominant Alzheimer's mutations from the DIAN study network. And those individuals had presenilin or APP gene mutations. And let's start with the premise for why you would compare brain amyloid accumulation in individuals with Down syndrome with those from an autosomal dominant mutation in the family for Alzheimer's disease. So in your paper, you really frame this as Down syndrome as a genetic form of Alzheimer's disease. So why don't you refresh folks on why we think of Down syndrome as a genetic form of Alzheimer's?
Down syndrome is the most common chromosomal abnormality worldwide. In the US, there's over 250,000 people who have Down syndrome. Down syndrome is really due to a triplication on chromosome 21. On chromosome 21 is this amyloid precursor protein, or APP. And in individuals with Down syndrome, they have 3 copies. And so they have an increase in the production of this amyloid precursor protein that then leads to an increase in amyloid. And amyloid is one of those pathological hallmarks of Alzheimer's disease. Now, in autosomal dominant Alzheimer's disease, that's also a genetic cause of Alzheimer's disease. It's not as common as Down syndrome, but it is also due to different types of mutations. And in particular, there is a mutation in presenilin 1 or presenilin 2, and those are different ways to cleave or cut up this amyloid precursor protein, or there's too much of this amyloid being produced, again, due to a mutation in the amyloid precursor protein. So like Down syndrome, these changes occur earlier in life with both autosomal dominant and Down syndrome. And it allows us to kind of start to make these comparisons to what is occurring in late Alzheimer's disease. Why we were very interested in looking at specifically Down syndrome is that there's really been a radical change in the last 20 to 30 years in the life expectancy of people who are living with Down syndrome. So in the early 80s and 90s, the average life expectancy was only about 20 years of age. And now most individuals are now living to much longer. And the reason is that individuals in the past often would succumb to either cardiac or pulmonary causes. But now, average life expectancy being almost into their 60s because of a lot of these medical procedures that can now correct many of those other comorbidities, now adults with Down syndrome are often passing due to complications due to Alzheimer's disease. And so we were very interested in comparing and contrasting these two genetic forms of Alzheimer's disease and how they lead to increases in amyloid. And so that's kind of why we were studying these two groups.
So in your study, you looked at cerebral amyloid using either CSF or PET measures of amyloid across these two groups. So run through what you found.
These are two common measures to look at how amyloid is changing in groups. So one way to do that is to look at the cerebral spinal fluid. And in these individuals, like we see typically in late onset Alzheimer's disease, we looked at this amyloid, or this ratio of the A beta 42 to 40, and we saw that it decreases with increasing amyloid deposition. And so people may be asking, well, how is that occurring? So what's happening is even as we're talking right now, we're producing amyloid, but typically it's cleared. And because of that, it's cleared into the cerebral spinal fluid, or the fluid that's surrounding our brain. And that's kind of this clearance mechanism. However, in Alzheimer's disease, what we see is that there's more amyloid that's being produced and then it's depositing in the brain. So there's less in the cerebral spinal fluid. And so in these kinds of forms, these genetic forms of Alzheimer's disease, just like we saw in late onset Alzheimer's disease, there's a decrease in the cerebral spinal fluid measurements of amyloid. And so both carriers of autosomal dominant and Down syndrome, we saw these changes, and we compared it to another way to look at amyloid, which is using positron emission tomography. We compared those cerebral spinal fluid measurements to these PET amyloid measurements. And what we saw was that for both autosomal dominant and people with Down syndrome, changes in these amyloid concentrations in the CSF were actually occurring even before we were seeing changes in the amyloid PET. And so this kind of allows us to place these two different measures in a time scale. But we also looked at individuals with using amyloid PET as a proxy and kind of tried to see how does that relate to cognitive changes. And so in both of the groups, we classified individuals as either cognitively stable, mild changes, Alzheimer's disease, or cognitive deficits or cognitive syndromes because of this. And what we saw is that for both genetic forms of Alzheimer's disease, we saw increases in amyloid deposition with increasing degree of cognitive impairment. So for both of these genetic forms of Alzheimer's disease, individuals with the greatest cognitive impairment also had the highest amounts of amyloid deposition in the brain. There is this slow but inevitable accumulation of amyloid in individuals who have genetic risk for Alzheimer's disease, and then that will then lead to these clinical consequences.
You mentioned the time scale. You did some modeling to examine, how early these changes in amyloid accumulation in the brain occur. So tell us about that. When does amyloid begin to accumulate?
Now, what's so interesting is that in these genetic forms of Alzheimer's disease, there is a predictability. So we know that these individuals will develop Alzheimer's disease. The question is, when will they develop Alzheimer's disease? And so in our study, we showed the potential usefulness of using this construct that's called the estimated years to symptom onset, or EYO. So EYO is calculated by subtracting an individual's age from the age at which their parent began to have symptoms, and that's for autosomal dominant, or from an average age of onset for Down syndrome, which we used from previous studies. Now, there is some variability in Down syndrome, and this is a limitation, and the same thing is also in autosomal dominant. So in some of our modeling, we looked at different ages. So we used either ages of 50 years of age, 52.5, or even 55 years of age, and we saw when were those changes in amyloid occurring. And based on these kinds of models, we started to see that it takes about 15 to 17 years before an individual has clinical symptoms. We're already seeing amyloid changes. So if we use, say, an age of 50 years of age or 52.5 and take, say, 17 years off, well, that gets us to age about 35 in Down syndrome. And what that suggests to us is that by the age of about 35, in a lot of our individuals, that's not for everybody, but a lot of adults with Down syndrome, they're already having amyloid PET changes that are occurring. Now, when we compared these two different groups, in general, we saw that there was a lot of similarities between these two genetic forms of Alzheimer's disease. However, we did see some differences. So we in particular saw that there were differences in the topography or location of where the amyloid PET was occurring in these two diseases. In both of them, we saw these deeper areas or these striatal areas being affected earlier. But one area, the occipital lobe, there seemed to be a little bit of differences. And in particular, in the medial occipital region of the brain, there was not as much amyloid deposition in Down syndrome.
Well, how do you summarize kind of what's new here and how this helps us as neurologists?
These findings are really the first to directly compare two genetic forms of Alzheimer's disease cross-sectionally. By doing this, we actually saw that there are more areas that are similar than are different for these two diseases. And we saw that these changes are occurring very early on in the disease process, and that often these deeper areas or striatal areas are affected, and then cortical areas are also affected. And as I said to you before, at age 35, we're already starting to see these changes. And that may say that those individuals at that age or even earlier may benefit from an earlier intervention. And we need to be thinking about potential clinical trials, especially for individuals with Down syndrome because of its relatively high prevalence.
So let's talk a little bit more about that. We've got new drugs entering the market, monoclonal antibodies focused on amyloid. What do we know, if anything, about the use of these drugs in Down syndrome? Because as you mentioned, this is the early accumulation and eventual development of dementia in this patient population makes them a good target potentially for these drugs. So do we have any data on that yet?
Currently, aducanumab and lecanemab are not approved for individuals with Down syndrome because they were not included in any of those clinical trials. And so what we need to do is to have adults with Down syndrome to be clinical trial ready. And so we are working, in particular, one of the missions of the ABCDS, or the Alzheimer's Biomarker Consortium for Down syndrome, is to have individuals trial ready. So for staging those individuals, looking at where they are in the disease process, and then have targeted interventions for them.
One last thing that I wanted to get into is thinking about, you mentioned late onset Alzheimer's disease, and this paper is focused on genetic forms of Alzheimer's, which are very rare in comparison to the common late onset Alzheimer's disease. And will you draw any distinctions or parallels between what you're finding here and late onset Alzheimer's disease?
By understanding these genetic forms of Alzheimer's disease, we think they could easily translate to the more common late onset Alzheimer's disease. Some distinctions between, say, these genetic forms of Alzheimer's disease and late onset Alzheimer's disease is that we know these individuals will develop the disease and we know when they're going to develop the disease. They're occurring at a younger age, so often in their 40s or 50s. And so other comorbidities are not as prevalent as what we see in late onset Alzheimer's disease. And so really, if we can start to understand these similarities, but also these differences, that will help us and guide us in anti-amyloid therapies, or even anti-tau or inflammation or other measures that we could think about for late onset Alzheimer's disease. If these therapies probably work in these genetic forms of Alzheimer's disease, we think that they'll then translate to the late onset AD. And so understanding these groups is going to be very, very important for our understanding of the pathophysiology as well as for potential treatments.
Great. Well, thank you so much for joining us today and for sharing your insight and perspective on this great work.
Hi, this is Greg Day from Mayo Clinic in Jacksonville, Florida. Today I have the pleasure of interviewing Erik Musiek, a friend and colleague from Washington University in St. Louis. Dr. Musiek is a dementia specialist and clinical researcher with particular expertise in the diagnosis and treatment of Alzheimer's disease. Keen listeners will recall a memorable discussion between Jeff Burns and Erik on the use of aducanumab for Alzheimer's disease that aired in January of 2022. In that interview, Erik and Jeff reviewed the FDA's controversial decision to approve aducanumab, a monoclonal antibody shown to decrease cerebral amyloid, for the treatment of patients with early symptomatic Alzheimer's disease, and the implications of aducanumab and the findings in the clinical trials that led to its approval on the amyloid hypothesis of Alzheimer's disease. Flash forward 1 year later, and the Alzheimer's disease community were again abuzz with discussions concerning potential approval of a second-generation therapy that also targets cerebral amyloid. This is called lecanemab. Top-line findings from the Clarity trial of lecanemab were first shared in the end of September, with detailed findings presented just last month at the Clinical Trials on Alzheimer's Disease meeting in San Francisco and published in parallel in the New England Journal of Medicine on November 29th. In light of these recent advances, we at the Neurology Podcast thought it was a good time to check back in with Erik Musiek for an update. Erik, thanks for joining us today.
Thanks, Greg. Happy to be here.
As you know, lecanemab's made a lot of headlines to date, generating excitement amongst patients, maybe some anticipation amongst insurers, regulators, and definitely health systems, and many, many questions regarding what this drug does and what the findings from the Clarity clinical trial mean for our field. Now, before you and I get into the details, let's talk about lecanemab. What does it do? How do we think it works? And what's different about lecanemab and aducanumab, its predecessor?
I think aducanumab and lecanemab have a lot in common. They're both targeting amyloid beta peptide, which is the constituent of these amyloid plaques that we think form in the brain at least a decade before people develop cognitive symptoms associated with Alzheimer's disease. Both of these drugs, lecanemab and aducanumab, have shown an ability to clear these amyloid plaques really efficiently from the brain of humans. They target slightly different species of amyloid. Lecanemab is specifically targeted at protofibrils, which is an oligomeric form of amyloid beta. But I think what they share in common is really their ability to remove the plaque from the brain within a few months of treatment. And that is, at least in my opinion, the likely mechanism by which they seem to be exerting these positive effects in patients.
And I think some other relevant similarities, maybe some differences, they're both given by IV infusion. Aducanumab was proposed once monthly. Lecanemab is going to be twice monthly, perhaps some additional administrative burden there. And while on the topic of approval, aducanumab is approved for use in patients and lecanemab is not yet. So I think we can round out some of those important points with that bit of discussion.
Yeah, and that 2-week infusion interval is actually really important. I think it's going to make lecanemab a little more difficult to implement in the clinic if it is in fact approved, which is a topic we can talk about. Aducanumab is, of course, FDA approved in an accelerated approval manner, but has not been approved for coverage by CMS and thus is generally not being used widely at this point. So we'll see if lecanemab changes that. And I think there's a lot of enthusiasm in the field that it could be the first drug that we really use widely.
Let's hone in on some of that enthusiasm. So I think we're alluding to that controversial approval of aducanumab and to the challenges in getting access to this medication for our patients. So what's different about lecanemab? Is the excitement warranted?
I think it is. And it's worth noting that we've had dozens, if not hundreds, of failed trials in the Alzheimer's disease space that have not hit their primary endpoint over the past 20 years. And so to have one that actually does hit all of its primary endpoints in a phase 3 clinical trial is exciting. There's certainly room for debate about the clinical efficacy and how to implement this drug, but I think there's certainly reason for enthusiasm, not only for lecanemab, but for this whole class of drugs, as there's others in the pipeline. And I think the main issue is that aducanumab never officially in its phase 3 trial may hit its primary endpoint. So the aducanumab trials were fraught with difficulty. They were stopped early because of perceived lack of efficacy. And then the data was sort of reconstituted and reanalyzed. And as a result, the trial never really had convincing phase 3 data for clinical efficacy. Both drugs showed very clear evidence that they can remove amyloid plaque based on amyloid PET imaging. But only lecanemab has really hit its primary endpoints in a clinical manner. So the main clinical endpoint for efficacy was this clinical dementia rating sum of boxes. And lecanemab did show a significant slowing of clinical decline in that primary endpoint, as well as in several secondary endpoints using other scales for clinical efficacy. So that's, I think, why the enthusiasm for lecanemab is higher than aducanumab, because it showed the ability not only to clear these plaques, but actually to, at least in the context of an 18-month study, slow the clinical progression of the disease.
Well, and another way of saying that is that 1.5 years into the study, seen that people that were on this drug were a little better off than those who were receiving the IV placebo. And as you've correctly said, this is the first study in our field to achieve this feat. And so I think I'm glad to hear you say that it's worth some excitement. I think it's certainly worth a discussion. On that topic, many people recognize that this study achieved the primary outcome that was set, of course, before the trial was put into motion and definitely before the authors sat down to analyze the results. But they'll argue that while the result was statistically significant, they'll say it's not clinically relevant or not clinically relevant enough. What's your take on that argument?
I think if this drug was very inexpensive and had absolutely no side effects, then it would be clinically relevant enough. It's difficult to tell from an 18-month study exactly how clinically efficacious this drug is going to be, because patients with Alzheimer's disease just don't decline that much in 18 months. And in fact, on this particular scale, the clinical dementia rating sum of boxes, it's an 18-point scale, but patients with Alzheimer's disease across many trials have been shown to decline about 1 point or 1 box per year. So the 18-point scale is really only engaged if you follow people for 18 or 20 years and through the full course of the disease. So in an 18-month trial, the placebo group only declines about 1.5 points out of 18. So a perfect drug that had 100% efficacy would only cause an improvement of 1.5 points. Lecanemab showed an improvement of about 0.5 points, so about 30% or a third of the decline was slowed by lecanemab. And so that's I think, a reasonable amount considering the constraints of the study. It's also worth noting that in studies like this, the drug takes several months to actually remove the plaques. So it's not as though the plaques are all gone on day one of an 18-month trial. It takes maybe 6 to 12 months to fully remove the plaques. So the amount of time in which you have to see a difference between the groups is not that long. Although I will say lecanemab did seem to show effects even relatively early in the course of the study. It's also worth mentioning that the patients in these studies, many of them have mixed pathology. Very few Alzheimer's patients have just pure amyloid pathology. And there are other things going on like tau pathology and alpha-synuclein and TDP-43, other proteopathies and other forms of inflammation and various problems in the brain that affect cognition. So we're removing one type of pathology with this antibody. And I think considering how complex the disease is, how complex the patient population is, the fact that we're seeing any sort of clinical response is definitely valuable. And it's a step in the right direction. Is this a cure? No. And it will really remain to be seen as the disease plays out and progresses if the drug has a continued effect in that will patients on the drug continue to show a 30% decrease in their rate of decline? Will they show an even greater decrease as the disease gets worse? We just don't know that yet. And I think that will be really the key element that tells us how valuable this drug is.
I think you've hit on a lot of the nuanced points here. We're talking about a progressive disease. And so even the on-treatment patients in this trial progressed. We can use terms like improved, but ultimately they were a little bit worse over 18 months, just a little bit less worse than those who were receiving the placebo. And so I appreciate you really calling attention to some of the challenges in this field. And 18 months, well, that's a year and a half. It's a long period of time, maybe not long enough to really get the scope on, does this drug change the trajectory of this illness? And I know that we can expect some further studies as patients who are now on open label treatment presumably continue on open label treatment. You touched on another point, though, that might be worth calling attention to, and that's that while we're focused on the primary outcome, the CDR, clinical dementia rating sum of boxes, the secondary outcomes were also positive in this study. So certain things like bedside cognitive tests that we may all be familiar with, other measures of cognition and function, and even some quality of life measures. What's your take on the secondary outcome measures here?
I think they're really promising, and it's very encouraging that they're all going in the same direction. Occasionally, when you see a trial that just has one endpoint that hits significance and the others don't, you have to wonder a bit about that. But these all seem to move in the same direction. The quality of life measures are very important, obviously, and the fact that we're seeing changes in biomarkers other than amyloid. So there's some CSF, phospho-tau endpoints that show pretty striking changes. There's another one, plasma GFAP, which measures astrogliosis or gliosis and inflammation in the brain of patients with Alzheimer's disease, which also showed a decrease in the patients treated with the drug. And so it's encouraging that we're seeing both biochemical measures that support our concept of disease pathogenesis, as well as clinical measures that actually matter to patients and caregivers, all moving in the same direction. So I think that's something that has to be considered when we look at this study as a very positive aspect.
Well, this is probably a good time for me to ask you, kind of a loaded question here. We're talking about biochemical measures, other biomarkers of this disease. What do the results of this trial mean for the amyloid hypothesis of Alzheimer's disease, for how we conceptualize of the different factors, things going on in the background that drive progression of this illness?
I personally do not believe that these drugs being used in symptomatic patients can really tell us that much about the amyloid hypothesis itself. The amyloid hypothesis at this point is really, I think, evolved to the point where we think of amyloid deposition as a very early step in the disease and potentially an initiator of further pathogenesis that occurs later, such as tau deposition, inflammation, synapse loss. And it's unclear at this point if removing amyloid after that cascade has already been initiated is going to be effective. And all those events occur years before people actually have symptoms of the disease. So right now in this study, we're looking at patients that have symptomatology. So they've had amyloid in their brain for probably 20 years by the time they even enroll in the study. So what we're really testing in these kind of studies is removing amyloid a viable therapeutic strategy in symptomatic patients? And I think this study, as well as some of the phase 2 trials and one of the aducanumab trials together, all suggest that, yes, it can help. That if you have selected the correct patients and you have them early enough in the disease course, that removing plaques does have some clinical efficacy. It may be limited. We'll see how long it lasts, but it does do something. But what we really need to do, and there are some studies going on in this vein, to remove the amyloid years prior to symptom onset to really test the amyloid hypothesis. And I don't think that's really been done exhaustively. And I think that this discussion about the amyloid hypothesis, it gets people worked up and in their camps and maybe not thinking objectively about the data at hand and how it can help people. So I don't think this will prove or disprove the amyloid hypothesis as much as some people maybe wish it would, but it can tell us if amyloid is a reasonable therapeutic target for symptomatic Alzheimer's disease.
And as you pointed out, more to come on that front as clinical trials are enrolling right now in patients who don't have symptoms but do have amyloid. And these are trials that also integrate lecanemab. So it should be exciting in the years to come. Now, we've been focused on sort of the high notes and the good things about this potential drug, but let's talk about side effects for a second. What are the meaningful side effects with this medication?
This whole class of anti-amyloid antibodies, as they remove plaques, they can cause something called ARIA, or amyloid-related imaging abnormalities. This comes in two flavors. There's ARIA-E, which is an edema, and there's ARIA-H, which is hemorrhage, usually microhemorrhage. It's thought that these symptoms are due to vascular inflammation causing either microhemorrhage similar to that seen in the setting of cerebral amyloid angiopathy or some mild edema around blood vessels. This was a problem in the aducanumab trial. It's an issue in the lecanemab trial and in other trials like donanemab, which are ongoing. And it seems as though many of these drugs can induce this, at least the MRI changes associated with this, in a decent percentage of patients, somewhere between 20 and 40% of patients receiving these drugs. So this is a fairly serious issue. In the lecanemab trial, the numbers were a little lower than in the aducanumab trial, which is a good thing. But still about 12% of patients that received the drug had ARIA-E or some degree of edema on MRI, and about 17% had ARIA-H, although it should be noted that 11% of the placebo group also had ARIA-H, which is probably pre-existing microhemorrhages from cerebral amyloid angiopathy. So somewhere between 25 and 30% of the patients in these trials are experiencing or are demonstrating some evidence of ARIA on MRI. Now, the vast majority of that is asymptomatic, and that's the good news. Only a small percentage, under 5% of these patients are symptomatic. However, when patients are symptomatic, it's fairly serious, and sometimes they have to be hospitalized and treated with steroids or whatever other agents we come up with to treat this new condition. And while there were no deaths reported in this particular trial, there are two other cases in which patients have died while taking lecanemab. In one case, they were treated with TPA. Another case, the person was on anticoagulants. And so it's not a drug to be taken lightly. I think patients need to be aware of this. They need to be aware that there are some side effects that are considerable that need to be monitored carefully with regular MRIs and with clinical evaluations. Patients that have a lot of medical comorbidities need to be very carefully selected for the drug. So I think when we first start using this drug, if it becomes approved, we're going to have to be careful in a clinical setting, both to monitor the patients and to choose patients wisely in that their risk is not zero.
We talk about how, thankfully, the vast majority of these side effects were asymptomatic, but that's in the context of a clinical trial where the patients are receiving regular assessments, arguably at a greater frequency than most of us can manage in the outpatient practice, and also receiving regular neuroimaging to look for early signs of edema or hemorrhage that could be associated with this medication. And I think that's going to be a challenge that faces us as providers as we look to not just improve our selection of patients, but also come up with algorithms that are both practical and efficient and allow us to correctly follow our patients, track and screen for these side effects, and intervene as early as possible to give this drug safely, provided that it's approved. Other challenges that we're going to have to make our patients aware of as well, and that could be the compound risks. If they do have stroke-like symptoms, like the case that you shared, who is provided with TPA, they're probably at a much greater risk of really adverse events like intracerebral hemorrhage that could lead to death and complicate their clinical care. So thank you for summarizing that experience and giving us more to think about there. What are the next steps with this drug, and what can we expect to see in the months to come?
Well, I think the first thing on the list is the FDA has to decide if they're going to approve the drug, if they're going to approve it in an accelerated manner as they did with aducanumab, or if they're going to give full approval, which could potentially open the door to the drug being used more widely. CMS, Medicare, has already said that drugs that are getting this accelerated approval based solely on their ability to remove amyloid are not going to be approved widely and are only going to be approved in the setting of a clinical trial. So a full FDA approval for this drug would perhaps change that calculus a bit and make the drug more likely to be approved by CMS, although both organizations have to make this decision. One would imagine that since the drug hit all of its primary endpoints in its phase 3 trial, that it has a much better chance of being fully approved. But as we've seen with the lecanemab situation, we never know what the FDA or CMS is going to do. So those kind of decisions could be occurring in the next few months. And then if they are approved, then we as clinicians really have to figure out how to use these drugs. So we're only going to have so much data, and we have the data before us that we're going to have probably when these drugs become available if they're approved. And so a lot of the things that you just mentioned, Greg, have to happen. We need to develop protocols for how to select patients. What are the requirements going to be? Are we going to require biomarkers for these patients? I would assume the answer is probably yes to that, but that's not widely available. How are we going to treat the patients? How are we going to monitor for ARIA with MRI? How frequently are these MRIs going to be done? And what's reasonable, both from a safety perspective and a cost and access perspective? And how are we going to pay for it? These drugs are going to be very expensive. There's a lot of patients that are going to want them. So there's a lot of challenges. This is not an easy drug. It would be nice if this was just a pill people could take every now and then and their problems would go away. But unfortunately, it's a fairly high demand drug for the patients, for the providers, for the healthcare system in general. Getting an infusion intravenously every 2 weeks, potentially for the rest of your life, is no small undertaking, with punctuated by MRIs every few months. So we need to figure out how to do that. Now, it is worth noting that the ARIA risk is really highest early in the course when the amyloid's really being cleared in the first few months of treatment. And so it's possible that the MRI imaging will be able to be discontinued or at least spaced out considerably as the treatment progresses. And it's also possible that the drug will not have to be given forever. So with some other drugs, I know Eli Lilly is testing this approach of clearing the plaques with a year or 18 months of treatment and then waiting and following biomarkers to see when the plaques come back. And perhaps that is an approach that could save people a lot of time and money. But all of these things are still unknown. So there's a lot of work for us in the field to do.
And important work at that. We know that it matters to our patients and certainly is going to matter to our future practices. I really appreciate you summarizing the Clarity paper for us, findings on lecanemab and comparing it to aducanumab. Any closing thoughts or comments when it comes to this drug and those that are likely to follow it?
Well, I think that this has to be thought of as a first step. That's where my excitement for it comes from. My guess is that 10 years from now, we may not be using this drug in this exact way. There may be others. We may have developed more strategies that allow us to use these drugs more effectively and more safely. So I don't think it's a good idea to throw the baby out with the bathwater here and just look at this trial and say, this wasn't perfect, that wasn't perfect, these drugs are no good. I think rather to take the positives here and say, how can we improve upon this? How can we build upon this? That those of us that treat Alzheimer's disease, as you well know, Greg, it can be frustrating. And it's very frustrating for patients and their families that they don't have better treatments that are disease modifying. And so I think we're close to a first step. Hopefully we'll be using these drugs in combination with other drugs, much like we treat cancer or even hypertension or cardiovascular disease with multiple drugs. That's probably what we're going to need for Alzheimer's as well. And perhaps this is the first step in that battle. So my optimism is high that we're getting somewhere and that this represents a kind of initial salvo and hopefully will be the start of some exciting things over the next decade.
If you're a listener that views this as a first step or a second step building on the history that's been established with aducanumab, I think we can all agree that we're hopefully moving in the right direction. I've been speaking with Erik Musiek about the drug lecanemab, the latest advance in Alzheimer's disease therapeutics. Findings from the Clarity trial can be found in the November 29th issue of the New England Journal of Medicine with the article titled Lecanemab in Early Alzheimer's Disease. A great discussion with more to come in the near future. Thank you, Erik, for sharing your thoughts, and thank you for listening.
Thanks, Greg.
Hi, this is Greg Day from Mayo Clinic in Jacksonville, Florida. Today I have the pleasure of interviewing Vijay Ramanan, a friend, colleague, behavioral neurologist, and director of Mayo Clinic's Alzheimer's disease treatment clinic in Rochester, Minnesota. Vijay is also an author on the paper published in Neurology titled Eligibility for Anti-Amyloid Treatment in a Population-Based Study of Cognitive Aging. Vijay, thanks for joining me today.
Thanks very much, Greg, for having me. Excited to chat.
Our regular listeners know that emerging monoclonal antibody therapies for treating patients with Alzheimer's disease are a pretty newsworthy topic. So we've been covering this topic since June of 2021, when the FDA made the rather surprising decision to grant aducanumab accelerated approval. Aducanumab was the first-in-class infusion medication shown to reduce cerebral amyloid burden in patients with early symptomatic Alzheimer's disease. But as we've discussed on this podcast before, the clinical trials that led to that accelerated approval left many questions unanswered, particularly questions pertaining to the safety and efficacy of this drug, while raising many other relevant concerns. Ultimately, Vijay, I think you'd agree with this. Those concerns generated lots of discussion amongst researchers, clinicians, patients, and payers, but culminated in pretty poor uptake of the drug in clinical practice. Flash forward to today, it's 2023. We now have this drug, lecanemab, the next in line monoclonal antibody supported by data from a well-designed and conducted clinical trial that clearly showed amyloid clearance from the brains of patients, again, with early symptomatic Alzheimer's disease, and a modest, yet statistically significant slowing in the rate of decline in patients receiving drug versus those receiving placebo. These results led to full approval of lecanemab earlier this year, with the medication now available for use in patients with mild cognitive impairment or mild dementia stages of Alzheimer's disease. It's this environment that your team's manuscript arrives in, testing the waters, I might say, and raising some key and very relevant questions about the potential generalizability of the criteria we use to select patients for the clinical trial for lecanemab and other relevant clinical trials. How generalizable are they to our patients in our clinics who we plan to use these medications on? Hopefully I summarized the lay of the field well to set you up, Vijay, but why did you and your team think it was important to write this paper now?
There's intense interest amongst all of us, clinicians, patients, loved ones alike, about new treatment options for what can be a really devastating disease. We think we all want as many options as we can get our hands on. And so having the news about lecanemab is a positive step forward for patients and for the field. We can also balance that against the nuances and complexities about these drugs. We know that drugs like lecanemab are not cures for the disease. Their aim is to modestly slow progression by acting on one element of the disease process. We know that these drugs are complex. They have their side effects, principally brain swelling and bleeding, referred to as ARIA, potentially other complications too. And as you weigh those things with the lifestyle changes of frequent infusions, traveling to centers for medication, MRI scans, other follow-up, all of this is potentially quite intensive for patients. And so even just from that high-level background, as a clinician, my instinct would be that these drugs are options, but will not be the right option for every patient with Alzheimer's disease. And as our field and related fields are tussling with these issues, our research team actually thought it was worth taking a step back. We know that clinical trials are not the same as clinical practice. They have different designs, different aims, but particularly for new and or complex treatments, these fit into that category. Clinical trials do provide an initial evidence base for gauging efficacy and safety. In other words, the population that's studied in a trial and the conditions under which they were studied provide some initial guideposts for translation to the real world. And so if we know from a starting point that lecanemab is approved for use in individuals with early symptomatic biomarker positive Alzheimer's disease, and we know that enrollment in lecanemab's clinical trial required meeting numerous criteria, there's a natural question that I think comes to mind, and that is, what if you applied those trial conditions, those criteria for inclusion and exclusion, to a population-based sample of individuals who fit that profile, who have early symptomatic biomarker positive AD? And the idea being doing so really ought to give the field and our patients some information on how generalizable that trial data may be to a broader population. And so that's why I think now is exactly the time when clinicians and patients in their counseling and pursuit of shared decision making around these new options would really benefit from this data. And so this effort was spearheaded by a colleague of ours, John Graf Radford, as well as Maria Vasilaki and first author Riona Pittick, and leveraging a data set that we felt was almost perfectly able to answer that question.
I agree. I think you're talking about the relevance to our patients, the relevance to clinicians, all those of us who are going to be prescribing this medication. And let's not forget the relevance to payers, anyone that's paying attention to the news, certainly anyone that's paying into insurance plans, including Medicare supplements, is aware that there's concern that this medication could roll out to the millions at costs in the billions or even higher. And so knowing how many patients in our clinical practice might be eligible is, I agree, a very relevant question for everyone involved. With that in mind, talk us through your cohort and the major findings of this paper.
This paper analyzed data from the Mayo Clinic Study of Aging, or MCSA. This is a longitudinal cohort study where participants are actually sampled from the population of Olmsted County, Minnesota. So this is a population-based sample. And those participants are seen for enrollment and at approximately every 15-month intervals thereafter, where they're getting quite comprehensive assessments, a visit with a neurologist, neuroimaging and fluid biomarker studies, genetic testing, detailed cognitive testing, and there's also regular abstraction of the medical records to identify comorbid conditions. And so having all of that multimodal data is a great foundation to try to answer the question that was on the mind of this study. Here, if we consider the more than 5,000 older adults who are part of the MCSA, just about 2,000 of those had amyloid PET scans, and that's important in thinking about this population of biomarker positive mild stage Alzheimer's disease. Among those patients, just under 900 were amyloid PET positive, so they had evidence of abnormal accumulation of amyloid plaque burden in the brain. And out of that group, 237 were classified clinically as having mild cognitive impairment or mild dementia. And so that group, that 237, were really the focus of this study. They had MCI or mild dementia and an abnormal amyloid PET. And for those individuals, we applied the clinical trial criteria for Clarity AD. And as a secondary portion of the work, also looked at the criteria for aducanumab's phase 3 clinical trials. So this included a variety of data points: cognitive test performance, functional assessment ratings, as well as active and prior neurologic and systemic medical conditions. And after we applied those criteria, we found that it was actually a small fraction, less than 10%, of those patients with mild symptomatic biomarker positive Alzheimer's disease who would have qualified for the lecanemab trial. And if you broadened the process and say didn't include some of the specific cognitive criteria that maybe are part of formal neuropsychological assessment, it's not like the fraction of patients who would qualify dramatically increased. They slightly increased. And we found a similar character of findings when applying aducanumab's clinical criteria to this population. And if anything, a smaller proportion of patients were eligible. So the key take home being, looking at a population-based sample of older adults from a clinical and biomarker standpoint, fitting the profile of patients who might be reasonable to consider lecanemab for. And it was actually all of the other criteria in those clinical trials that would have excluded more than 90% of them.
So thinking about the clinical trials, I think we all appreciate that it's hard to get into a clinical trial. We really are selecting, hopefully, those that are maybe most likely to benefit and least likely to be harmed. What are the key trial inclusion and exclusion criteria that led to that 90% reduction in potentially eligible patients to receive this therapy in the clinic?
For lecanemab, it turned out that more than half of those initial 237 patients would have been excluded based on cognitive or functional measures required for inclusion in the trial. So these included the CDR score, which is a standardized rating scale of cognition and function very widely used in the field of Alzheimer's disease in many research studies, as well as a score of memory performance, which is typically part of neuropsychological test batteries. In some cases, a mini mental state exam score. Medical comorbidities were really the other big factor, with some of the most frequent exclusions coming from cardiopulmonary conditions, things like coronary artery disease or significant heart rhythm abnormalities or a history of cancer. The two other big categories, one, coexistent neurologic conditions were also quite common exclusion factors. So these would, for example, relate to things like seizure disorders, Parkinsonism, or prior intracranial injuries or major head traumas. The other major reason actually was MRI exclusion factors. So because of the risk of ARIA with these drugs, and particularly with that risk being magnified in individuals having a higher burden of amyloid angiopathy, which is often coexistent with symptomatic Alzheimer's disease. There are some requirements both in the FDA label for lecanemab as well as in most concept of appropriate use that, for example, there be 4 or fewer microhemorrhages on an MRI prior to treatment, or that there not be any sign of superficial siderosis or very large cortical infarcts. Turned out in this population-based sample, nearly 40% of individuals with that early stage biomarker positive AD had MRI exclusions at the time of their PET scans. These were some of the most common reasons why that 90% plus would not have qualified for the clinical trials.
I think there's an important point to be made here as well, that you're talking about the Mayo Clinic study of aging. This is an engaged population-based research study. You've got people coming in multiple times for imaging. Is it fair to say that these patients who form the research population you're looking at may be even healthier than our typical clinic population? So maybe not as healthy as the clinical trial population, but perhaps still healthier than the patient that I'm going to see later on today. Does that seem a potential concern?
It does. And I have to say, Greg, thinking more broadly, that matches very well to what I see as a day-to-day clinician in cognitive neurology. In many ways, this profile from a population-based research study sort of matches what we see in the real-world clinic, but individuals who tend to enroll in studies like this, if anything, might be medically healthier than their real-world counterparts. And so I think this is important information for all of us as clinicians and for our patients to understand. We can start from a foundation that clinical trials and clinical practice are not exactly the same. They're not meant to be exactly the same. Treatments cannot simply exist in the real world as pure 100% extensions of what happens in clinical trials, but accepting the limitations of what we know now from clinical trials, I think will be quite critical as we're thinking about what is a new stage in our management of Alzheimer's disease.
You commented on the potential exclusions simply based on MRIs. That emphasizes the importance of working with our neuroradiologists to develop key high throughput protocols to identify these small, often small microhemorrhages that could present a serious safety risk for patients coming onto this drug. And then there's the whole set of patients that won't get in the scanner that have many different indications for MRIs. And we need to be mindful that they weren't in the clinical trial. They're not included in your Mayo Clinic study of aging data set, and they really shouldn't be included in the clinic-based population receiving these drugs. So you talked a little bit about clinical practice and how we're going to translate these findings. Let's talk for a moment about the implications of your findings for the real-world practice. Are you suggesting that these drugs are likely to be offered to less than 10% of patients with Alzheimer's disease overall? Or is your take that a lot of patients who receive these drugs may not do as well as what we saw in the clinical trials, or may experience substantial safety risks, potential adverse events?
This paper, to be clear, is not making recommendations on which patients to treat or not treat with lecanemab. That's a separate issue beyond the scope of this particular study. And I'll refer interested listeners. There are manuscripts from expert author panels on appropriate use recommendations for lecanemab and aducanumab. There are also manuscripts in the Green Journal which focus on implementation of these therapies in clinical practice. But having said that, there is certainly a general consensus in the field, particularly among subspecialists who are seeing these patients in great focus, that for such new and complex medications, those clinical trials do give us some initial guideposts. And it's interesting that most of the concepts about appropriate use of agents like lecanemab in the real world are actually fairly closely aligned to the conditions of the clinical trials. And I think that is simply reflecting that is the population where we have that initial data on efficacy and safety. We will learn more as these drugs are utilized in the real world. One could certainly imagine there could be use of lecanemab, for example, in patients who may not have qualified for the clinical trial based on some measure of inclusion or exclusion, but where use is adhering to the FDA drug label. So there are not overt contraindications to use, but there are uncertainties, as at least to a degree, as to safety and efficacy. And so here I think is where an emphasis on shared decision making will really be critical. So relaying to patients that the question on their mind, the right question, does it work, doesn't have a simple and straightforward answer. There is nuance, and all of us collectively accepting that nuance and accepting that there is complexity in those discussions, that there are going to be some cases for which we don't have a firm, hard set prognostication prediction for our patients, but that where use could still be very appropriate. And so this paper, I think, is helpful for patients to have an initial expectation and an understanding that the data we have from that clinical trial population, yes, represents a fraction of the patients that will actually potentially even be receiving this drug. And I think with additional real world experience, we are going to learn more. So concepts of appropriate use in clinical practice as of today, I am quite confident will evolve over the coming 6, 12, and 18 months as we gain more experience and as we also get more data on other drugs in class, which are in late phases of clinical trial or review.
Really, when we're thinking about how we're going to roll these drugs out, I think it seems like what you're suggesting is we've got our clinical trial guideposts. We've got this unique, perhaps very small percentage of overall patients that are enrolled in the clinical trials. And based on findings in that highly selected group, we have a reasonably thin benefit towards efficacy over safety concern. And then that's fueled a lot of ongoing discussions. And it's probably reasonable and practical if we're seeing patients that fall outside of that clinical trial population, as you said, we're going to need to engage them in shared decision making to recognize and accept ourselves and help them accept that their perception of efficacy, their likelihood to benefit, may be less than patients in the clinical trials, or I suppose maybe even potentially greater. And same thing goes for safety. And so setting up barriers, guideposts so that we know how to monitor those patients, catch the potential adverse events early and intervene as necessary. Thinking about adverse events, thinking about safety concerns, and thinking about efficacy, and thinking about our population. You've got your study population here. A lot of them were excluded. Some of them in your clinic, you might have made the decision to include. How are you interpreting what would be sort of relative contraindications and absolute contraindications? What do our listeners who may be thinking about starting to use this medication in their patients need to know about there?
The answer is not going to be one size fits all. And there are at least two important planks, one of which you led off with just a moment ago, that anyone clinically considering use of these medications, they are more complex. They are different in so many ways compared to our historical options for managing Alzheimer's disease. And so there really is an imminent need as a field and at an individual clinician and practice level to make sure that that systematic infrastructure for taking care of patients, both to get appropriate patients selected for treatment and to have the mechanisms, the personnel, the testing needed to follow patients, especially because not only are these treated patients going to need fairly regular scheduled safety monitoring, MRI scans and other things, there's the potential for unscheduled or unpredictable events. And so upfront, making sure that that infrastructure and those processes are in place are really critical. It is not simply a matter of having a new option that's FDA approved and having the ability to prescribe it. It's much more involved than that. I think the second piece of this is I would hope studies like this and others in category provide our clinicians with a foundation to have those 5 or 10 minute discussions with our patients. I think you and I in our clinical practice have been having these for many months, and especially over the last 1 to 2 years as developments around these drugs have been progressing. And I find that there is just no substitute for taking that time and engaging with our patients on their goals of treatment, their preferences and their values, and then bringing them back to the context of what we know and don't know about these drugs. And so I find it is actually very helpful in my clinical practice to mention that our best estimates are that less than 10% of patients in the general population with early stage Alzheimer's disease will likely be very strong candidates for these drugs. And then moving from there, there's a second stage. Some patients are going to have absolute reasons why they cannot be prescribed these medications. You hinted at several of them earlier. MRI contraindications, the inability to get an MRI, histories of things that would very clearly predispose to severe potential side effects, things like brain bleeds in the past, use of anticoagulant medications. And so those represent a part of the discussion. And if those things are there, it's important for us as clinicians to be upfront with our patients and not let that end the discussion, because Alzheimer's disease management really is best served when it is comprehensive. There are many different strategies. We accept that those strategies right now are not cures, but many different strategies that I think are critical to individualize to the person in front of us. And then the second thing is where those cases are very complex, where there are no absolute contraindications, no clearly overt safety concerns, but where there are some hints in the picture or some uncertainties, being upfront with our patients about those things as well, and then engaging them to weigh on an individualized basis that potential benefit of slowing of disease progression. Does that sit well with them? Is that well balanced against the potential for risks, the lifestyle modifications, the cost, all of the other things that fit in here? And I hope where this paper adds value is in giving a high-level overview, both to clinicians and patients, that though we have these new options, they really may not be the right option for every patient with Alzheimer's disease, and that does not need to end the conversation. There is more to come in this field. There are other options that are not anti-amyloid monoclonal antibody therapies, and so it's a facet in our discussions and our management. It's an exciting time and a good step forward for patients, but there's much more to come.
I love that response, Vijay. Keeping the patient at the center, recognizing that this is one step in the right direction. There are more steps to come. Thank you for translating this from the clinical trial population to a population-based cohort study. I know we can all look forward to some further great work from the team and from many others who are already treating patients with these medications as we look to understand how does this drug respond in a true clinic population. Who is it that should absolutely be receiving it? Who absolutely should not? And what are all the considerations to weigh in between? Thanks for taking the time to discuss this important paper. I've been speaking with Vijay Ramanan, one of the authors on the paper titled Eligibility for Anti-Amyloid Treatment in a Population-Based Study of Cognitive Aging, which you can and should read in Neurology. Thanks, Vijay.
Thanks so much, Greg.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.